So this is a 35-year-old female. This patient woke up and noticed that she had blurred vision. And she also states that when she gets up too quickly, she has loss of vision, which was described as a complete blackout that lasted only a few seconds and then returned. She also stated that 3 months prior to her visit, she had history of intermittent vomiting. And today her visual acuity was 20/20 in the right and 20/25 in the left.
So this is
Going just right into it.
This is a color from this photo of the right eye. The media appears clear. The nerve looks edematous. Can't really make out the margins. The vessels, parapapillary vessels are obscured. And then the rest of the vessels look okay in this picture. Macula looks normal at the fovea, but near the nerve nasally appears to have some exudates as well. Some parapapillary hemorrhages, I believe, as well, superior.
Sada, let me see that pointer. Use a quick pen. Let me show you something. Hold on, I'm curious if you see this. Just a sec. This is all this very fancy. One. Yeah, you can do you can blow up. Oh, you can highlight. Oh, there's one more. Hold on. Yeah, it blows up. Isn't that cool? Can you see that on the internet, people?
No, whatever you're doing, I can't see. I'm really excited, so I know you're doing something.
I see your change.
Actually can enlarge whatever you're pointing at. So when you're pointing at it, it blows it up. It's kind of cool.
Oh, now that you did that, maybe there's some choroidal holes there.
Oh, sweet, yeah.
All right.
All right, go ahead.
Okay, this is the color from this photo of the left eye. Media appears clear. Nerve looks significantly elevated 360 with disc margin blurring. The vessels are also obscured as they're exiting the disc margin, and the disc looks hyperemic as well. Otherwise, the vessels look of normal caliber and actually maybe a little bit tortuous, but otherwise look okay. In the macula, yeah, looks okay in the macula as well. Maybe a little yellow spot there in the center of the fovea, but I don't know if that's just archive. So this is a IR photo of the right eye. Looks like it's focused on the nerve. The nerve appears edematous. There's like patchy hypo reflective areas, maybe just kind of highlighting the edematous nerve. And then this is the left eye. Looks like there's more either hyper reflectance here. And then the significant elevation of the nerve as well, 360. And this is an OCT of the right eye. Looks like a wider field here. Temporally, we can see or on the right side of the image, you can see the nerve, and it looks elevated and edematous. The rest of the retinal layers look fairly normal. There's good foveal contour. There is some hard exudates within the retina near the nerve, superior papillary. And I see the posterior hyaloid membrane attached there as well. This one's of the left eye, OCT. Looks like the nerve here as well appears elevated, and then the retina looks otherwise nice and organized with a good foveal contour. So I guess this one's more focused on the nerve. OCT, still looking at edematous, maybe some thickening there. Otherwise, no exudates that I see here, and the retinal layers adjacent to it look pretty normal. And then this is also the right eye. focused on the nerve, significant elevation of the nerve. With less of the retina seen in this picture here, but what I can see appears to be normal. The left eye OCT, again focused on the nerve, appears elevated, maybe a little bit of edema in the retinal layers to the right there, temporally closer. And then the fovea has, there's good foveal contour and the rest of the retina looks normal.
There are some papers when you're looking at these scans through the nerve who make a big deal about the area right where the nerve meets the retina. Again, it's a little hard, and it's not something we hardly ever look at, but I'm using my little arrow here to point to the little cyst there in the outer nuclear and inner nuclear layer. But and sometimes basically a lot of times you're trying to figure out, is it drusen or is it edema, like we talked about in the other thing. Sorry, go ahead, Scott.
Another cut through the nerve, the OCT appears elevated, retina appears normal. Am I missing something in these multiple cuts here?
No,
Okay.
just that it's very swollen. It's just,
I didn't think you missed anything. You're doing awesome.
Okay, so this is an OCT RNFL. Looks like there is significant edema of both nerves. And then when looking at the RNFL thicknesses, the right eye has some maybe thinning inferiorly, some patchy areas, and then the left eye looks normal. I can't really read the numbers there,
if
but
you use your magnifier, you'll be able to.
oh yeah.
Look at that.
Okay, so that looks like maybe.
I still can't. So one thing on this, Scott, are you gonna talk about the
Oh.
veracity of that test stuff?
Am I going to talk about what?
The veracity of the test, the truthfulness? Is it like fake news?
Definitely. I feel like it's just so
Definitely.
swollen that I can't, like.
I wasn't
get
going
it
to say
into
too much
RNFL
more than
thickness.
that. Do you have something that you want to add too?
Well, just that the numbers aren't right. So the segmentation algorithms on the OCT is not necessarily very good. So you can look at the little tracing there, let me see, can I do a control plus? I'm afraid I'm gonna screw something up. No, that's not doing anything. Okay, I'm gonna do that. You can look at the tracings where the computer gets the go up a little bit. Up a little right there. That the tracing, it's not getting it right. It's tracing out the RPE or something. It doesn't know where to put the little thingies. So basically those, it's so swollen, it just can't get a good measurement.
And I think they look to be in the 200s or something. the thickness.
Right, it's trying, and you
Yeah.
can see the little black line, but it's not getting it.
Right.
All right, go ahead, sorry.
Oh, no, you're okay.
Okay,
So with the presentation and all of the images and OCT and everything else, because we can open this up to more than just Saba, so we're not just picking on her. Anyone want to throw out something they're thinking?
So I can at least get started. In the setting of a young female who is having vomiting, episodes of transient vision loss upon standing, probably lasts a few seconds, I think you said. I'd be concerned for increased intracranial pressure with the bilateral optic disc edema, cerebral sinus thrombosis as well. And then sorry, I'll let other people kind of chime in here.
You're on a roll. I mean,
Tumor.
keep going.
Pseudo tumor, but a real tumor.
Pseudo. Broadly, what are some things that can cause optic nerve swelling? So you're going to increased intracranial pressure, right? What's another one? Yeah, ischemia. So ischemic optic neuropathy. You get a young woman with
Optic neuritis.
optic neuritis. So inflammation, ischemia, increased intracranial pressure, and then the last one was the nerve drusen. So those are, and I don't know if you guys do more than that. Then there's like weird stuff like tumors and infiltrates, but when I'm looking at swollen nerve, I just go through those four, and they're pretty easy to differentiate because they all are distinct.
Sometimes we'll throw in an FTA.
That-
Sometimes we'll throw in an FTA.
Oh gosh,
as
yeah,
well.
nowadays, yeah, everybody's got
Yeah,
something.
if there's any AC cell, they're getting.
Yeah, so this was the list that I came up with, Dr. Cohen added a couple things as well. And our patient had a dural venous sinus obstruction, which you got right away. So that's awesome. So the testing that we ordered for our patient included an MRI of the head with and without contrast. We also got an MRA of the venous phase and an anticoagulation workup. And that testing was consistent with benign intracranial hypertension and showed a bilateral transverse dural venous sinus thrombosis with complete occlusion of the left and near occlusion of the right. Anticoagulation workup was positive for lupus anticoagulant and ANA. And as an aside, our patient is overweight, but not obese. And this is the report, just so you guys believe me.
Did you study her on Diamox, or did you just send her to the emergency department to get the blood test?
I think she was neurology center to me afterwards to follow the nerves.
Oh,
So
okay.
she was already neuro worked up.
Because I've seen some people, they'll start the Diamox right away and then send the patient over. Others that don't. So.
Yeah, I'm not sure.
I think Dr. Rucker would say if you know it's elevated intracranial pressure, then that's just what I'm on. But I guess we have to send them to the ER to know that it's elevated. I see that now.
Okay, and here's a picture of the MRA venous phase. I'm not the most radiographically inclined, but I had a little help from a radiology friend of mine who said that it's impossible to determine based on one view where the occlusion is, but he was guessing right here, right here. Can you guys see my mouse?
Yes,
Yeah.
you can.
Okay, perfect. All right, so like Dr. Cohen said, this was a neurology patient that was inherited afterwards. So after the testing, the patient was treated with Eliquis for anticoagulation and a pretty hefty dose of Diamox at 2,000 milligrams twice a day. And then this is a RNFL that was taken at follow-up of the patient. So you can see that the swelling is starting to subside.
How long after was the image taken?
I believe it was roughly 2 months.
Let's just say January
Yeah,
2020.
January 13th, and I believe our patient was seen in November. So yeah, almost 2 months. All right. So I was just going to
I'll
talk.
throw in before you move on. I love following nerve fibers on these patients. So I have a number of optic nerve edema patients where you follow the nerve fiber because you can titrate the treatment and see how they're doing. It's so nice to have it. Once the nerve fiber kicks in where it's actually correct, it's a nice, it's a really good way to follow people and say, okay, you're getting better, you're getting worse, or, uveitis too.
What kind of follow-up do you have? Like what kind of time delay between like adjusting your treatment and then repeating the nerve fiber there?
Probably a month or two. So, once until they're getting better, once they're getting better at 2 weeks.
So you're titrating the Diamox or the Dural?
I usually tell them what to do. I'll say, no, I didn't do it on this one. But I usually say, okay, you can back off, or it's not working, they might need surgery, maybe the diagnosis isn't getting it, or it's something else altogether. You always hope your diagnosis is right, but it's hard to know. All right, sorry, guys, just want to further.
You're okay. So dural sinus thrombosis is when you have a clot in the venous drainage system of the brain, and it occurs in 5 per 1 million people every year. Compared to ischemic strokes, it's more likely to affect females in younger patients, being defined as, that should be less than 50 years old, I'm sorry. So risk factors are related to Virchow's triad, which includes hemostasis, changes in blood composition, and changes in the vessel wall. So there are some hormone-specific risk factors, which a couple of papers alluded to why it could potentially affect females more commonly than males, which include oral contraceptives, pregnancy, hormone replacement therapies, prothrombotic states, hypercellular and hyperviscosity conditions, cancer, both from the hypercoagulable state, which is induced because of that, and local compression, hematologic disorders, and other systemic diseases. The pathophysiology behind it relating to us is that the dural sinus are venous channels that allow CSF to drain from the subarachnoid space into the systemic venous system. So when you have a thrombus that occludes the dural sinuses, there's a backup in the venous pressure, which then impairs the CSF drainage, which causes the increased intracranial pressure. So an increased intracranial pressure, there's a compensatory increase in CSF absorption by the arachnoid granules, which also takes place through the dural sinuses. So since the arachnoid granulations are disrupted, the CSF backs up, leading to stasis, which causes swelling of the optic nerves. And that's what causes the papilledema that we were seeing. So there was a nice study called the International Study on Cerebral Vein and Dural Sinus Thrombosis, which was a prospective study, the largest one done on cerebral vein and dural sinus thrombosis, that involved 89 centers over 21 countries. 624 patients were involved. So a couple big takeaways that I thought to include were that headache was present in 88.8% of patients. It was the most common symptom. It also found out that headaches may be the only presenting sign. If you have cerebral vein sinus thrombosis, in the absence of a headache, it's more common to be in an elderly patient or a male when compared to the normal presentation. There's also a higher incidence of seizure or paresis and a lower incidence of papilledema without headache. Other presenting signs and symptoms include visual loss and changes, seizures, mental status change, aphasia, stupor, coma, sensory defects. And then just to include some outcomes, 8% of patients with this presentation died within the follow-up period, which was 16 months. And risk factors for unfavorable outcome included being male sex, greater than 37 years old. Sorry, the little box was blocking this. Coma, mental status disorder, intracranial hemorrhage on admission, CNS infection, and cancer. And most deaths were primarily related to the underlying cause, specifically malignancy. So when you have a patient who presents this way, this is the testing that you want to order, which is what was done for our patient, but you want to get an MRI or MRV. T2 weighted MRI with MRV is the most sensitive test for identifying. The appearance depends on the age of the thrombus. So you can kind of read through how different thrombi will look depending on how acute or later along the course it is. Non-con CT is usually the first test ordered. It's not very specific, and it's only abnormal in 30% of cases. But if you can't get one, you can add a CTV. You also want to get other tests to look for hypercoagulable states, CBC, CMP, PT, INR. And then different managements. You can manage your patients with medical therapy, which is anticoagulation. Low molecular weight heparin is typically the medical therapy of choice. Other measures resemble the treatment of intracranial hypertension. Serial lumbar punctures can reduce CSF volume, but remember, you're typically anticoagulating these patients, so you're going to want to hold that, which you may or may not want to do in acetazolamide. Surgical therapy, optic nerve sheath fenestration can be considered. You can also consider shunting if intracranial hypertension remains elevated. And then endovascular thrombosis and mechanical thrombectomy have not really played a prominent role in the treatment, but you can consider them in cases of severe neurologic deterioration despite use of anticoagulation, venous infarcts causing mass effect, or hemorrhage. So as we talked about before, prognosis, early death occurs in approximately 3 to 15% of patients. Cause of death is mainly secondary to transtentorial herniation due to mass effect. Late death, usually related to the underlying disease, and the study showed that more often than not, that's going to be malignancy. But complete recovery was observed in 79% of patients. And these are my references. Thank you, Dr. Cohen, for the case.
That was excellent. Thank you.